Welcome ViaQuest Psychiatric and Behavioral Solutions employees. Today we're going to be talking all things psychiatric medications. My name is Cassandra Skull. I am the Executive Director of Psychiatric Nurse Practitioners. Hopefully you guys have already taken Mental Health 101. This is going to build upon some of this. I don't expect you guys to be experts in this. But again, this is just a nice overview. No matter what position you are in the company, whether a TBS in the community working with our IDD folks, or a TBS or a therapist out in the LTCs, or a nurse, or even our nurse practitioners. This is just a nice general overview. Many of our clients are on some type of psychiatric medications, and it's good for everybody on the team to know just a little bit and have a baseline understanding to help everybody on the treatment team take care of our clients. So the objectives for this presentation today is going to understand how medications impact mental health symptoms, the benefits, risks, contraindications, side effects, and what can happen if there's a missed dose of medication, and how the implications of exercise and diet can affect the use of medications. Understanding the importance of taking medications as prescribed, being able to identify signs of non-adherence or when a client isn't taking medication, and also potential drug reactions when you combine prescription and non-prescription medications, know how to identify early signs and efficacy or if a medication isn't working, the needs for laboratory studies, tests, or other monitoring procedures, the risk associated with medications during pregnancy, and the expected course of use of medication, including discontinuation. We also want to provide information on the availability of financial support and resources when a client is having trouble obtaining the medications that have been prescribed, and what to do in the event if there's a question or concern about a medication the client is taking or has been prescribed. So that's quite a bit. So let's get started. Mental health medications are psychotropics or psych meds. These are all medications that are used to treat the symptoms of mental health disorders. So we're typically treating things like schizophrenia or schizoaffective disorder, depression, bipolar disorder, anxiety disorders such as PTSD or panic disorder, and attention deficit hyperactivity disorder. These medications can be used in combination with other treatments such as psychotherapy, TBS, and even some over-the-counter medications. This guide is going to describe the types of medications we use to treat various mental disorders and the desired outcome, possible side effects of medications, special considerations and precautions, and when to contact either the doctor, your NP, or whoever is your prescribing provider. So before the doctor, nurse practitioner, or other prescriber decides what they're going to prescribe, there's a lot of considerations that go into it. So what kind of mental health condition are we treating? What have they used in the past? What are they currently using? How old are they? Are they male or female? Are they of a smaller body size? Are they of a larger body size? What other medical conditions do they have? Do they smoke or they drink alcohol? How do their liver and kidneys function? What has worked for family members in the past? What kind of allergies do they have? Are they taking any kind of herbal or vitamin supplements? What kind of diet do they have? What kind of exercise do they do? So the first class of medications that we're going to discuss are the antipsychotics. And previously, in earlier iterations of this talk, we used to do it by diagnosis and not drug class. And I decided to change it up this year because I think it's very important because the drug classes treat a lot of different varieties of mental health conditions. So our antipsychotics are most often used to treat schizophrenia. However, they can be prescribed for bipolar disorder, treatment-resistant depression, issues with sleep, obsessive compulsive disorder, and dementia with behavioral disturbances. Um, these drugs work mostly on the dopamine neurotransmitters in the brain. And, a lot of times now when you're watching TV, especially in the evenings, it's common to see ads for things like Latuda, Vraylar, Rexulti. And a lot of times they're not talking about schizophrenia. They're talking about bipolar depression, or they're talking about treatment-resistant depression. And a lot of times you'll hear them say, when your medication isn't working for you, try Vraylar or Rexulti to help your antidepressant work better. What people don't realize that these are antipsychotics. So there are two types of antipsychotic medications. We have our older medications, which are called your typical antipsychotics. So you're looking at Thorazine or Haldol or flufenazine, which used to be called Prolixin, but it is only carried in generic now. So that's how old a lot of these medications are. And then you have your atypical antipsychotics, which are your newer generation. A lot of our patients are on these, including Risperdal, Zyprexa, Seroquel, Geodon, Abilify, Invega, and Clozaril. An important note for Clozaril that there's a lot of increased side effects, and you only use this type of medication when a couple of other medications have failed in the past. So when we prescribe an antipsychotic, what we're looking to treat with schizophrenia is a decrease in excitability or paranoia, for them to have less withdrawn behaviors. We basically want to be able to treat those symptoms of schizophrenia. Maybe for treatment-resistant depression, we're looking for them to be less withdrawn again, more social, maybe less suicidal ideation. These medications do come with a lot of side effects. It can be things such as drowsiness, dizziness when changing position, especially when a patient goes to get up really quick. That's called orthostatic hypotension. So when you change that position really quick, go from a laying to a sitting to a standing type positions, they can get very dizzy. So a lot of times we always counsel our patients to be able to change positions slowly. That gives the body some time to be able to deal with those changes, and then you won't have the decrease in blood pressure, which then will cause the dizziness. They can cause blurred vision, rapid heartbeat, sensitivity to the sun, skin rashes, issues with menstrual problems, weight gain, change in metabolism. The side effects, if you look at the atypical antipsychotics, they have a lot more drowsiness, sedation, issues with movement. Some of the newer medications, the atypicals, they really have more issues with weight. And when you think of weight gain, what do you think of? Metabolic syndrome. So you got your diabetes, your weight gain, sometimes high blood pressure, high cholesterol. It all kind of feeds in together. One side effect of all antipsychotics, even though it's a little bit more common in the typical antipsychotics, is something called tardive dyskinesia, or TD. This is a movement disorder that you will see for people who have been taking antipsychotic medications. The longer you are on an antipsychotic, the more antipsychotics you're on, and then of course the type of antipsychotic increases your risk for TD. You'll see things such as frequent blinking or eye rolling, lip smacking or puckering. They'll do a rolling of the tongue or a chewing motion. They can have rocking and swaying, or twisting or jerking of your upper or lower limbs. And it's very different than what you'll see in something like Parkinson's disease. In Parkinson's disease, a lot of times it's very rhythmic. It can be bilateral. When you see TD, it's just more jerky, and it's not rhythmic. All patients that are assessed by ViaQuest, by our psychiatric nurse practitioners, are given a scale called the AIMS, which is the Abnormal Involuntary Movement Scale. And this is something that we use to assess for TD. What's really nice is now that we have drugs that are able to treat this, such as Ingrezza and Austedo. Up until 2017, they would give different types of medications, but it really didn't treat the underlying issue. The other thing is with TD, it can get confused with other movement disorders, such as restless leg syndrome, akathisia, Parkinson's disease. So it's really hard sometimes to differentiate, and it's still very undertreated. It's important that we do recognize when our patient is having symptoms of tardive dyskinesia, because it can have a very negative impact on their life. They can be embarrassed. They could have trouble doing their everyday task of daily living. So when you're looking at a client or patient, you may see, like we said, the involuntary movement of the tongue. It may dart in and out. You may have them do, like, their limbs may be moving, but again, it's not a rhythmic, it's more of a jerking. We had a client that had that, and people thought it was them being sexually inappropriate. And here it was TD that was causing more of a thrusting aspect of his lower limbs. It can be in their neck. It could cause severe pain. It can be in their facial muscles. And people can be embarrassed because as they're talking with you, they're doing a lot of maybe grimacing like this. And it's embarrassing. It can be in their trunk muscles. It can cause issues with breathing. Patients can actually hurt themselves from a lot of these things. You can see other involuntary movements, like I said, maybe repetitive finger movements, but it's not with a Parkinson's. You'll see like they'll have a pill rolling. With TD, a lot of times they'll have a movement and they will control kind of how they move. So you'll see maybe somebody is constantly playing with their bracelets because they know that they have TD or they have this movement. They're embarrassed by it, so they try to make it look purposeful. They often will have a duck-like gait, and you'll see an inability to remain physically still. You can say, hey, sit still, pay attention, and they're just moving all over the place because they can't help it. So antipsychotics come with a lot of risk. You got to be careful when prescribing to somebody who is pregnant or can become pregnant or maybe breastfeeding. All drugs that are given to a pregnant woman can have some type of side effect. A lot of times we don't know exactly. The view on medications in pregnancy have changed quite a bit. It used to be that a lot of times you would try to get mom off of all medications or as little medications as possible. But what we have found through a lot of different research is that the best thing for a pregnancy is to have a healthy mom. And sometimes it's weighing the pros and the cons of these medications to keep mom healthy, because we know a healthy mom leads to a healthy baby. You need to use these medications cautiously with clients that have any kind of cardiac issues. We know that a lot of drugs in this class can prolong a certain part of the heartbeat, which can lead to them developing a fatal arrhythmia and dying. It can decrease the seizure threshold, and it can cause something called neuroleptic malignant syndrome. And this is an adverse reaction to an antipsychotic. What you'll see is muscle rigidity, fever, and altered mental status. So people will be, if you think about it, they're sweaty, they're stiff, and they're confused. And this is an emergency that needs to be treated right away. I actually had a patient develop this, and sometimes when, especially patients in our long-term care facility are already sick to begin with, you don't recognize it right away. So we're always thinking sweaty, rigid, confused neuroleptic malignant syndrome when they're on an antipsychotic. And then you also have to have contraindications. So if anybody has had any hypersensitivity to any medications, it should not be used with people with angle closure glaucoma. So this is a type of glaucoma where it has a blockage of the drainage of the eye, and that increases the eye pressure, which can increase vision loss. A lot of medications will have something called an anticholinergic side effect. So if you think anticholinergic, you think drying. So if you don't have a lot of fluid in your eye, it's going to lead to like a gunky eye, and that the fluids is not going to be able to drain. And it should not be used with clients who have central nervous system depression, so a decreased drive to breathe, because these can be sedating. Because these drugs can be sedating, you have to be careful if you have a patient who is on hypertension medication, if they drink alcohol. You really have to consider these type of factors going into it. We know a drug, phenobarbital, may increase the metabolism and decrease the effectiveness of antipsychotics. Phenobarbital is used for seizures. You can have worsening central nervous system depression when you're putting it in with, say, they have pain medications such as opioids, our sedatives or hypnotics like our Ambiens, or let's say like our benzos such as Ativan, our antihistamines, which is like Benadryl. All of this can play into decreasing a person's drive to breathe, which could cause them to pass away. Lithium may decrease blood levels and the effectiveness of some of our antipsychotics. So that's why it's so important when you're, especially our nurses or like our house managers, that when they go in and they're having their client be assessed by the nurse practitioner, for us to know every single medication that client is on. And this is a caution for all medications. Always notify your mental health provider if they have side effects that are very sudden, severe, or it's causing the patient to not be able to do what they usually do, their activities or daily living. A lot of times our TBS workers, our nurses are in the homes and in our LTCs. They're seeing these patients a lot more than we do. We'll make a change in medication or start a medication. And a lot of times I always say, you guys are our eyes and our ears. If there's something that seems wrong, say something. It's always very important. We're all a team surrounding the patient. And so it's very important for you guys to keep an eye out for this type of stuff. The next drug class we're going to discuss is probably our most commonly prescribed medications, which are the antidepressants. And I think it's funny because when you hear antidepressant, you're thinking, oh, it treats depression, which is true, but it also treats a variety of everything else. It treats anxiety, obsessive compulsive disorder, panic disorder, post-traumatic stress disorder, bipolar. It can treat pain, migraines, issues with sleep, and eating disorders. Antidepressants are very commonly used, so it's important for us to have an understanding of these medications. There are a lot of drugs that make up our antidepressants. There's several classes. Our most well-known and probably most commonly prescribed class are our SSRIs, or our selective serotonin reuptake inhibitors. Those medications such as Prozac, Zoloft, Lexapro are very common to see. We also have a lot of SNRIs that we prescribe, so our selective norepinephrine reuptake inhibitors, so things such as Effexor, Cymbalta, and Pristiq. You do see Cymbalta used a lot for pain, so if you have patients that have underlying pain conditions such as fibromyalgia, you'll see a lot of times that they'll be on Cymbalta. We have this class that's called others because we have a lot of antidepressants that have unique mechanisms of action and don't fit neatly in one box or the other. So Wellbutrin is commonly used for depression. It's used off-label actually as well for attention issues, and it can have some appetite, a decreased appetite as a side effect, so sometimes it can be used for somebody undergoing weight loss. On the flip side of that, something called mirtazapine or Remeron we see a lot in the long-term care facilities for patients who are having issues with weight gain or appetite or sleep, because we know a side effect of that is appetite stimulation and sedation. Trazodone we see a lot everywhere. It used to be used mainly as an antidepressant, but it needs to be utilized in large doses. Well, they had to stop using it for depression because it caused too much sedation, so now a lot of people are prescribed it to help with sleep. Some newer antidepressants are Viibryd, Trintellix, and Fetsima. When I think new, I think expensive, and later on we'll talk about prior authorizations and helping patients afford medications. And then we have two of our old school classes, which are less likely to use, our tricyclics and our MAIO inhibitors. And we will discuss those in down a couple slides here in a second. So when we prescribe an antidepressant, we're usually either treating depression, symptoms of depression, or symptoms of anxiety. Again, it can encompass everything, but what we're looking to do is just have a decrease in overall symptoms. And this does come with some side effects on a lot of these medications that can cause issues such as headache, GI upset, so nausea, constipation. It can cause drowsiness or insomnia. It can cause people to feel agitated or jittery. It can cause issues with sexual dysfunction, dry mouth. It can cause issues with urination and sometimes even blurred vision. So some contraindications we have to think about with the antidepressants is very similar that we've heard previously with our antipsychotics. If you ever have had a reaction to one of these medications, it's very important for your provider to know. Again, with the narrow angle glaucoma and really being cautious in use with pregnancy, we do know lots of SSRIs have been studied in pregnancy. Many babies are born very healthy on these type of medications, and you'll probably get sick of me saying healthy mom, healthy baby, but again, it's very important for your healthcare provider to know if your client is trying to get pregnant or it is pregnant. Some precautions, you want to make sure anytime you use medications in the elderly, you got to be careful if they have pre-existing cardiovascular disease. Some of the medications can have the anticholinergic side effects, so again, thinking dry eyes, dry mouth. If you have dry eyes, you're going to have blurred vision, constipation, and it may cause you to have to reduce the medication because of the side effects. A lot of times we start on a start low, go slow. And sometimes these medications can take 2, 4, 6, 8 weeks to really cause symptom relief. When you have a patient that has bipolar disorder, the antidepressant should not be prescribed alone. It can be stimulating and cause a rapid switch from depression to mania. So a lot of times you'll see an antidepressant be used with a mood stabilizing agent or an antipsychotic medication. I actually had a patient that was I had diagnosed with depression. She did not show any signs that we had talked about that she had let me know about of mania or a bipolar disorder. And as I increased her Prozac from like 40 milligrams to 60 milligrams, she turned into a manic phase, and actually it required hospitalization. She started stealing. and spending money and making just some poor judgment choices because she became manic. And unfortunately, we do a very thorough history, but sometimes it's subclinical with the bipolar disorder, and you don't find it out until they've had a bad reaction to an antidepressant. As promised, we're going to talk a little bit about the tricyclic and the MAOIs. Tricyclic medications can cause hypertension, tachycardia or rapid heartbeat, and convulsions if you combine them with the MAOI inhibitors. It can prevent a therapeutic response to some hypertension drugs. It can cause CNS depression when used in combination with other CNS depressants. And then these really do have a bad anticholinergic effects. So things such as like Benadryl, which is also an anticholinergic medication, when combined with the tricyclics, can cause a worsening of those side effects. The other thing with tricyclics is that they can definitely cause issues with heart rhythm, especially they're very easily overdosed on. So somebody who has suicidal ideation or has had suicide attempts before, you consider not giving them a 30-day supply. Sometimes we'll do a week supply so that it's less likely if they were to overdose to cause an issue. For our MAOIs, you have to worry about something called tyramine, which is something that is found in a lot of foods. It's a naturally occurring amino acid that helps regulate our blood pressure. And MAOIs blocks that enzyme that breaks down the extra tyramine. So you can get too much tyramine in your blood, which can cause increased blood pressure and can lead to a stroke. Right now, we can probably maybe have 1 or 2 patients in all of ViaQuest that are on something like this, but it's very important to know. Because there are a lot of foods that have tyramine, stronger aged cheeses, cured or smoked meats, and beers on tap or home brewed beers. The next class of medications we're going to discuss are our mood stabilizing agents. They treat mainly bipolar disorder, but can be used for schizoaffective, treatment-resistant depression, impulse control disorder, such as intermittent explosive disorder. They can be used for treatment-resistant anxiety. It can also be used for dementia with behavioral disturbances. These medications include things like lithium, Depakote, Tegretol, Lamictal, and Trileptal. So when we're prescribing a mood stabilizing agent, we're looking to either have a resolution of the symptoms of mania, which are like hyperactivity, pressured speech, poor judgment, need for little sleep. We want to decrease incidence of mood swings or a decreased incidence of the acute manic episodes, or we want to see signs of less depression, decreased delusions or hallucinations, a less social withdrawal, and flat and blunt affect, or just kind of the way you present. Some types of side effects we see are drowsiness, tremors, nausea, diarrhea, weight gain, again, dry mouth, blurred vision, headache, increased thirst, dizziness, and confusion. A lot of times what people discuss that really they complain about a lot of times can be the drowsiness or the weight gain, and sometimes a tremor. Lithium was our first modern mood stabilizing agent, but it comes with several contraindications and precautions. It should only be used where blood levels can be closely monitored. It has a small therapeutic range, meaning that it can be easily too much in your blood and can cause a lot of issues. It is definitely contraindicated in lactation and pregnancy. Caffeine-containing herbs, tea, coffee may decrease lithium serum levels and efficacy. And large changes in sodium intake may alter how you eliminate lithium. So if you have increased sodium, it will increase the renal secretion. So lithium is a salt. It's very finicky based on what kind of fluid you're taking in. So it's important for people on lithium to drink. They need to make sure that they're drinking, but they can't be drinking too much or too little. So it is common sometimes for when people get sick and maybe they're vomiting, they have very low intake, their lithium levels can rise quickly and they can become toxic actually. For Depakote, the contraindications and precautions, they also have blood work that needs to be done on a regular basis. Depakote is a little less, is a little more friendly when it comes to therapeutic range. The big thing with Depakote is that it can be hard. Lithium's hard on the kidneys, Depakote's hard on the liver. And so you have to watch your liver enzymes, and if your liver is not working correctly, you can get high levels of ammonia. This is also contraindicated in lactation and needs to be used cautiously in pregnancy. It can increase testosterone in women. It can result in polycystic ovarian syndrome, which can affect the menstrual cycle and fertility. It can cause a skin rash, and then it can also increase suicidal ideation. So it's very important that you monitor for changes in mood and behavior. Whereas lithium a lot of times is a common adjunct or an added medication to somebody that maybe has chronic suicide ideation, that lithium is very commonly used to help treat that, where Depakote can cause some of the suicidal ideation. Our next drug class are anxiolytics or anti-anxiety medications. These are used to treat the various anxiety disorders such as generalized anxiety disorder, social anxiety disorder, post-traumatic stress disorder, panic disorder, sometimes when there's been an acute stress or crisis. And it also can be used to treat aggressive behaviors. We see this both with our patients with intellectual or developmental disorders, but we also can see it in the long-term care setting as well with our patients with dementia. Remember that many of the antidepressants treat anxiety, and a lot of times they are the first line to treat the anxiety compared to some of the drugs that we're going to be discussing on the next slide. So when you think anxiety drugs, our most common that you think about are benzodiazepines. Sometimes they're called benzos. The most common are Klonopin, Ativan, Xanax, and Valium. They work to decrease the anxiety and related symptoms by working on a neurotransmitter called GABA. And if you think of GABA as the brake of the brain, that's how the benzos work. They're very effective, but we usually prescribe them short term because there is a large abuse potential. They do come with side effects such as upset stomach, blurred vision, headache, confusion, grogginess, nightmares, and respiratory depression. And they are contraindicated if you have issues with breathing, such as COPD or sleep apnea, kidney, liver issues, and in the elderly, especially the elderly, can increase falls and confusion. Our next anti-anxiety medication is called Buspar or Buspirone. This is a more novel type of drug. It acts on serotonin and some of the dopamine receptors. It is non-sedating. It's often dosed several times throughout the day. A lot of times if SSRI has been ineffective for anxiety, a lot of times you'll see Buspar be prescribed. It can cause dizziness, headaches, nausea, some nervousness, lightheadedness, excitement, and some trouble sleeping. It's contraindicated if you have severe liver or renal impairment, or if you take other serotonin-containing drugs. You have to be careful. So there are a lot of different drugs that work on the serotonin neurotransmitter. And so a lot of times you hear them, like I just said in my previous slide, you got to be careful on how many of these type of drugs you prescribe, because they can cause something called serotonin syndrome. So we have a lot of different drugs that work on serotonin in the brain. Our SSRIs, our SNRIs, our MAOIs. There are medications called triptans. Tramadol is a pain medication. St. John's wort is an herbal supplement. And all of these things can impact serotonin in the brain. And what we know is that it can lead to something called serotonin syndrome. And what you see is a mental status change, so agitation, confusion, fever, sweating, tachycardia or rapid heartbeat, high blood pressure, and a lot of times you'll see tremor or rigidity, hyperflexia, or clonus, where they're just completely like contracted. And this is a medical emergency. It sounds really similar to neuroleptic malignant syndrome, and they do have a lot of overlapping symptoms. And there's a lot of times somebody can be on antipsychotics that can cause neuroleptic malignant syndrome, and they could also be on serotonin agents. So sometimes you know that there's something wrong and you're just trying to figure it out. What I hear though is, one person can be on 3 different serotonin agents and have no issue. And then you can prescribe the smallest dose of an SSRI and that patient develops serotonin syndrome. So it's not dose dependent, it's kind of patient dependent. But we do know the more you have in your body, the more likely you are to have it. But again, a small dose can impair one person and not the other. Our next class we're going to talk about are attention enhancing drugs. So these are medications that are going to be aimed at treating attention deficit hyperactivity disorder, or ADD. Again, you're treating the inattentiveness, impulsiveness. It can improve social interaction and overall attention span. There are 2 types of attention enhancing drugs. We have our stimulants like Ritalin, Adderall, and then we have our non-stimulants such as Strattera or Intuniv. The big thing with our stimulant medication is that they are a controlled substance and they can only be filled for 1 month at a time. Sometimes this can be impair patients being able to get these medications because they can't get easy refills, and there are just definitely more hoops to go through to get these type of medications prescribed. The stimulants have several side effects, including decreased appetite, weight loss, insomnia, headache, stomach pain, nausea, dry mouth, irritability, mood swings, anxiety, and it can increase your heart rate and blood pressure. It can sometimes worsen people who already have pre-existing tics. And there's a rebound symptoms where you get increased irritability or hyperactivity when the medication starts to wear off. Side effects of non-stimulants include drowsiness, fatigue, decreased heart rate and blood pressure, and nausea and stomach upset. Contraindications for these type of medications, of course, again, pregnancy and lactation should not be used with or in conjunction with your medical provider. Avoid using in clients with psychotic personalities or suicidal homicidal tendencies. It's contraindicated in glaucoma and severe cardiovascular disease. You need to be used cautiously in clients that have a history of hypertension, diabetes, or in the elderly. It can cause continual use may result in a psychological dependence or addiction. And a lot of times what we'll do is the therapy, you can interrupt it or take med holidays to determine how well the patient is doing, and to decrease the level of dependence. And it can increase anxiety symptoms. So a lot of times you'll see it's called med holidays. So during the summer months, a lot of times children will stop taking their medication. This allows them to have an increased appetite and hit their growth milestones that they're expecting. Children are monitored very closely to make for sure that the decreased intake because of the stimulant medication doesn't cause them to fall off or on their growth curve. So we know that we monitor height and weight for children, and sometimes if they're not eating, what you'll see is they stop growing like they should on the trajectory, and so sometimes they will either have to have a decrease in dosage, or sometimes they will try different medications. Something new that I added this year is to discuss our dementia-related drugs. They are used to help with memory, thinking, daily function, or behavioral changes. They do not cure dementia, but they can slow the symptoms or improve the quality of life for the patient. What I say is the end is always going to be the end with these medications. So let's say from the time of onset to the time of where it progresses to severe dementia is going to be 5 years. These medications aren't going to make it last longer than 5 years, but what they're going to do is the quality of life and the memory that you do have will be more preserved throughout those 5 years. There are two different main groups of medications in these. One are called cognitive enhancers, which support memory and thinking. And then we have behavioral and psychotropic drugs that will manage mood, sleep, or behaviors. So the two big classes of memory enhancers are our cholinesterase inhibitors. These are things such as donepezil, galantamine, and what they do is they boost the brain chemical acetylcholine to support memory and thinking. These have a lot of side effects, including nausea, diarrhea, loss of appetite, and dizziness. Galantamine can be very harsh on sleep as well. And then our other classes are NMDA receptor antagonists, which is Namenda or memantine. And what it does is it helps regulate brain activity, and it can improve memory and daily function. Some common side effects are headache, constipation, confusion, and dizziness. I'd like to highlight two of the patient populations that we serve. Those in long-term care tend to be older, and we know that the elderly are more impacted by medications. Their kidneys and their liver just don't function like that of a younger person. Therefore, medications can build up in their system. They can have more side effects. They can get toxic. They can have really bad reactions. So it's very important that we start low and go slow. The other thing is that long-term care is very heavily regulated. I think what they say is that it's the most heavily regulated of all industries in the entire United States. In April of 2025, there was new guidance issued on non-pharmacological interventions, which is wonderful. I think sometimes we see a problem, and a lot of times our first gut instinct is to prescribe a medication. But there are a lot of different things that we can do to support a patient in a long-term care facility. Therapeutic behavioral support, our mental health nursing, having increased visits. There's a lot of different things that we can do that aren't medications. The other thing is that there's very heavy scrutiny on the use of antipsychotics and giving the diagnosis of schizophrenia. Antipsychotic use in long-term care has been very high historically, And a lot of that is to do with behaviors and keeping people compliant and easy to control. And so in the early, like 2007, there was a push to really start to examine this. And over the last 20 years or so, there's been a push to decrease the amount of antipsychotics used. One way to do this is to tie that to reimbursement. So we know facilities that have less antipsychotic use tend to get more reimbursement. And one way for them not to report the antipsychotic use was to give a diagnosis of schizophrenia. Well, what happened is that the diagnosis of schizophrenia increased exponentially after these guidelines came out. And so now what CMS is doing is that they're analyzing the diagnosis itself of schizophrenia to make for sure that that patient actually has it, and it's not to get out of being dinged, so to speak, on their quality measures for that reimbursement on using an antipsychotic. The other large population that we serve are people that have either a disability, a developmental disability, or an intellectual disability. And we know people with IDD may respond differently to medications. Sometimes they need higher doses or different combinations to reach the same effect for someone who doesn't have IDD. It's very important to monitor side effects because it can be harder to recognize, especially if a patient is nonverbal or have limitations on their verbal ability. Things such as sedation, weight gain, restlessness. I only had one patient when I worked on a locked psych unit actually pass away. And it was a patient who had IDD, who was on Clozaril, which is a heavy-duty antipsychotic that is very heavily regulated in terms of blood work because it can cause issues with your white blood cells. But the number one reason of people having bad outcomes with Clozaril is because of constipation, because of that anticholinergic effect that I talked about previously. And what happened, that individual was so constipated that they end up having a bowel obstruction and end up passing away. And so it's very important that we are really in tune to our patients with IDD to be their eyes and their ears a little bit more because they can't always relay the information to us. The other thing is the use of PRN medications or as needed medications have very specific regulations depending on if it's in a group home or ICF setting. And I know we have a handful of youth homes, and that industry is even more heavily regulated, and there has to be very specific language and care planning involved when you're utilizing medications. I want to discuss medication efficacy. So efficacy is the ability to produce a desired or attendant result of a medication, and this may diminish over time, so it's important to notice symptoms. So if a medication will have reduced efficacy, you'll start to see old symptoms to begin to reemerge. There's a thing that we call Prozac poop out. And so a lot of times people who have been on Prozac for a long time will notice that their medication is no longer doing what it used to do. So it is important to note changes and make sure that the prescriber is made aware of that information at follow-up appointments. If the behaviors are causing a safety concern, of course, you need to contact your provider immediately. It is also important to know the difference between a symptom of their disorder and disease and a typical appropriate action to something that makes them upset. So not every action needs a medication. So a lot of times, let's say someone lost a loved one and they're normally grieving. They're upset, they're crying, but they're still eating, they're still doing things that they need to be doing, but they're obviously devastated. That's a normal grief reaction. You do not need to treat that with a medication. Another example is that the example that we give in the slide, What's a symptom? What's a behavior? Sally has started hitting herself and staff every day when they leave the house. She runs into the street and she's putting herself and others at risk. Is that a symptom? Is that a behavior? That looks like that's more of a symptom, and that's something that we need to be worried about versus a reaction. So Billy got angry at his and pushed his roommate because his roommate took a toy without asking. That's a learning opportunity where you can teach coping mechanisms, and not every action requires a medication. It's really important to determine if is that behavior a cause of because of a medical or dental issue. We always try to eliminate the physical before we treat the mental. It's important that your patients are taking their medications as directed. That's called medication adherence. You want to make sure that patients aren't splitting their pills or their doses, skipping pills, or taking medications as needed all the time on a schedule basis. So let's say somebody is prescribed an anti-anxiety pill, let's say Ativan, 3 times a day as needed for anxiety. Are they just taking it scheduled? Are you just giving it scheduled 3 times a day because they may have anxiety? That's not how that medication was prescribed. You want to only utilize it in terms of meeting the criteria that that patient was anxious. No over-the-counter herbal supplements without the approval of the provider, because there's a lot of drug interactions. And then the other thing I want to highlight is that you should only have one provider treating the mental health condition. We don't want several providers prescribing different psychotropic medications. It can cause severe interactions, and it's just not good medicine. So let's say you have a patient that is getting their medication management from ViaQuest, but also has been seeing an outside provider. It's important to let the ViaQuest provider and the outside provider know, and then we can give the patient or their family or loved ones the choice of which provider to go to, so that we're not treating the same problem with different medications, because that's just a recipe for disaster. And then if a client doesn't want to take their medication, it's important to try to figure out why. Is it a lack of understanding? Do they understand why they're taking it? Do they agree that they have that condition? Are there side effects or adverse reactions to it? Are they unable to afford the medication? Are they just straight out refusing? So if a patient is refusing medications, it's important to let the provider know, because if we go to reassess them and go to increase the medication because we feel it's not working, well, it's important for us to know they're not taking it to begin with, and then to figure out why. If it's a thing of affording the medications, there's a lot of resources, and we will discuss that in the next slide or two. And you want to make sure that your clients are getting lab work or any tests that are ordered. A lot of times we'll do EKGs to look at cardiac function, how the heart beats, because a lot of the medications, if you remember, can impact cardiac function. We want to make sure clients are going to all of their follow-up appointments, including medical and mental health. So there's a lot of barriers to medication compliance, and a lot of it is not the patient's fault, so to speak. So they can be forgetful or have cognitive impairment. It could be because of the side effects. Every time I take my medication, I feel tired, or tremors, or weight gain. Maybe it's too complicated. Maybe the medication is 3 times a day. It's really hard to remember, say, 2 medications 3 times a day, whereas if you only had to remember the 2 medications at bedtime, it would be a little bit easier. They can have lack of insight or motivation to continue their medications. Maybe they don't feel like they have a mental health condition. There could be issues with cost or access. Perhaps their closest drugstore closed down and they don't have access to a vehicle. There could be stigma or cultural beliefs. Sometimes people feel like people who need medication, I've heard, oh, you're weak, you just need to have better diet and exercise, and you'll be fine, you need to snap out of it. It could be an issue with the client-provider communication or relationship. Maybe the patient doesn't trust the provider. And then also it could be substance use or unstable lifestyle. If somebody is homeless, we know that there's a less likely ability to maintain medication compliance because maybe their medications get lost or stolen. So it's very hard sometimes, even despite our best efforts, for patients to continue on medication or be compliant. Insurance companies choose what medications they pay for and which ones they don't. One way that they do this is having a process called a prior authorization. This is often on medications that are either expensive, not on their formulary. So the purpose of these is that it ensures medical necessity and guideline-based prescribing. It promotes cost-effective care, and it helps prevent overuse or unsafe use of medications and encourages the use of preferred evidence-based alternatives. But prior authorizations can take a lot of time and energy. It delays treatment initiation and continuation. It is so frustrating. It seems like the formularies change at the beginning of the year, and then all of a sudden there's multiple prior authorizations that your provider has to complete for many of their patients, and it's for a medication that sometimes the patient's been on for years. It increases patient frustration and decreased satisfaction. And when you're having to do these prior authorizations, sometimes they will have to go without medications until it's been approved, or having to go on a different medication if it's denied or delayed. Medications are expensive, and issues with affordability is very common. So prescribers should try to prescribe generics whenever possible. And you can ask the provider, hey, is there something cheaper that can be used? Is there a generic? There's things called GoodRx or Single Care. They're pharmacy discount drugs. You can call around and compare the prices at different pharmacies. There could be quite a big difference between Walmart, Walgreens, CVS, Drug Mart. You can request 90-day supplies, or mail order options tend to save a lot of money. A lot of the manufacturers, so something like a more new medication like Trintellix, which is an antidepressant, they actually have a copay savings program for people to help them afford their copays. You can refer the patient to assistance programs for uninsured or underinsured. You can consider lower cost therapeutic alternatives. So let's say an antipsychotic that I like to prescribe a lot is something called Invega. It has a very similar mechanism of action as Risperdal. I know that Risperdal is very much cheaper than Invega. So if for some reason my patient couldn't afford Invega and I thought that medication would be the most helpful, then I would probably try Risperdal instead. The other thing is you could use, when it's safe, especially in our group homes or the long-term care setting, you can use tablet splitting to reduce the cost. So let's say our patient is on 20 milligrams or 10 milligrams of Lexapro, and I know 30 tablets of 10 milligrams cost $100, but 30 tabs of 20 milligrams also cost $100. Well, I could prescribe the 20 milligrams and have them only do half a pill, and that would save them basically 50%. We can also encourage social workers or case managers to connect patients to the variety of resources. So there is a lot of things out there to help patients afford medications. Another thing I wanted to touch base on is a lot of you will start hearing things about genetic testing or GeneSight. GeneSight is one of the main companies that offer genetic testing to look at how patients metabolize certain drugs. This is a cheek swab that prescribers can order, and then it can help with recommendations regarding what medications are more likely to be tolerated than others. It also will look at an enzyme required to convert folic acid into folate, which is important to make neurotransmitters. That's called the MTHFR gene. And this test shows if there's a variation in this gene, then it would limit the client's ability to make L-methylfolate. And so, again, it's just giving us additional information. GeneSight is not a magic wand. I have, when you get your results, it shows the different drug classes. So your antidepressants, your anti-anxiety, your antipsychotics. And it gives you a list of all the medications. Some are in green, some are in yellow, some in red. And basically, it's the ones in green are ones that you can use as directed. The ones in yellow may have some moderate gene-drug interaction, and in the red they could have a significant drug interaction. I've had people do really well on medications that are in the red, and I've had people have severe reactions to medications in the green. It's just helping you make some informed choices when you're deciding on what medication to prescribe, and gives you an increased risk of choosing the right medication more quickly. So when you're working with your clients, there's going to become a time when you need to know when you need to notify the provider. So if a client has missed medication, you want to report what medication they missed and how many doses they missed and the reason that they missed. If a client has a new medication prescribed from another provider, it's important for us to know to make for sure there's no interactions or if that may change our plan of care. When the client has received labs or other testing ordered by another provider, you can either have the results faxed or email your provider. If the client has been hospitalized, when they are discharged, let us know. It is best practice for us to know immediately and to see that patient within 7 days. It's also important for us to know what kind of medications that patient is now taking. If there's been any abnormal or severe side effects, or if you have any questions and concern about a medication, don't guess, just reach out. We will help you. Maybe it's like, I think they said take this pill 3 times a day, but what time? I thought they said this time, but I don't remember. It's okay to reach out to ask for clarification. That leads me to my final slide, is that we're all on the same team. The patient is the center, and nobody is more important than another person. We're all trying to have the patient do the best that they can in the situation that they're given. So be it the med management with the nurse practitioner, mental health nursing, our TBS, our therapy, we're all surrounding the patient and trying to have them have the most optimal functioning that they can given the circumstances that they're currently in. And it's important that communication exists between all 3 of us. You don't want to work, it's called working in silos, where we're all working separately, because when we work together, that's when we know our patient is going to do the best. I know this has been a long presentation. Thank you so much. I look forward to meeting all of you who have taken this class. Welcome to ViaQuest. And if you ever have any questions, you can always email me at cassandra.skull@viaquestinc.com. I love everything about medication management and ViaQuest, and I would love to discuss it with you.